Hello and welcome to Differential Discussions. I'm Melissa,
And I'm Dave.
and today we have a guest with us, Toula. Toula,
Hi.
welcome.
Hi. Hi. It's nice to see you guys again. I'm really happy
Yes.
to be here.
Yes, we're glad to have you back again. Wink, wink, Yeah.
Thank you.
We do our
I'm happy to
recordings in
be
bunches.
I'm happy to be back again.
Super fun. So, Melissa, what are we looking at? There's a lot of purple dots on the screen here.
There's a lot of purple dots. Yeah, so we're going to look at a prolymphocytic leukemia. We've looked
Fun.
at CLL, and it had prolymphs in it, but we've never looked at a PLL.
So this will be fascinating.
Yes.
So yeah, I mean, like right away, if I put this on my scope in 10x, like you got my attention.
Absolutely.
You know, in a clinical environment, I get the white cell count. I know that there's a storm brewing.
Agreed. One thing that I always look at with a very high white count is their ability to lose that contact inhibition. But I notice with the lymphocytic leukemias, they don't necessarily always do that. Like you don't see that clustering effect of the cross-talking among the cancer cells. And I have a little bit of a background in cancer cell biology research, so I talk about like 6 hallmarks of cancer and how all of those kind of factor in, but you don't necessarily see them in a PLL or a CLL. Sometimes they lose it, sometimes they don't. It's just the nature of the behavior of cancers.
There's a couple of little groups though, right? Like
yeah, a couple of them, but not the majority. Like you know, when you look at a typical really raging AML, that literally they're wall to wall talking to each other and figuring out where to hit next, I guess. You know. But I don't typically see that with some of the lymphocytic leukemias. You know, it's interesting.
You think that has to do with more of the mature neoplasms are not quite as gang related, I guess, versus the immature ones. When you have blasts, they're more,
that could very well be the case. Yeah, they're when you think about them, yeah, that maybe it's a mature phenotype that they kind of are off doing their own thing, but you're still seeing that same sort of clonal behavior. You know, absolutely. That's a good point, Melissa. Yeah.
You want to drop onto 40 or actually before I drop to 40, let me kind of swivel out to the feathered edge and then back. Okay. Yeah. The other thing it's important to say is this isn't an albumin prep.
Okay. So we expect to see a lot of wait, it is an albumin?
It's not.
Okay. So we expect to see some smudgies.
Absolutely. Oh, definitely some there. Looking at this, yeah, there might be more happening. So I'd probably make the decision to do a 200 cell diff at this point, with that many white cells, just to make sure I have a good representation. But yeah, there's definitely a lot happening there as well. But I wonder if we'll see. Maybe if we go down to 40, we'll see if we see any more smudges along the edge. Interesting. Oh, wow. That is beautiful.
So I just see nucleoli just peeking at me.
The owl eyes. Yep.
Nice.
Yoo-hoo, I'm here.
On 40, because this is 40 and we can see it really prominently.
Yep.
Like that one, look at that. Woo!
Gorgeous. Yeah. Gorgeous.
So really troubling.
Yeah. And there's the clustering happening like up here. Yeah.
Well, I'm going to go back to a better area on 40.
Absolutely. Sure. Absolutely.
This will be a fast diff, you know.
One or two fields.
Bright spot there, but yeah, there's a lot of cancer here, it looks like, fortunately.
14, 15. So it's looking at the 40, first thing, like estimate wise, I'm seeing probably 15 or so per field, maybe more, 2, 4, 6, 7, 11, 12. If you count these, 15, 16.
And that should correlate to an elevated white count for sure.
Yeah, for sure. Yeah.
So maybe we can get ready for oil. What do you think?
Yeah. See, that's what's so interesting about in general, the mature lymphocyte neoplasms is that they've got so much heterogeneity in what they look at. Like you've got this nice young phenotype here. Very nice nucleoli looking at you. But then you've also got these more mature, very condensed chromatin forming a little bit of a cleave here.
Yep.
Yeah.
There is
And
a
there's
to the maturity, right? Yeah.
Yeah. Yeah. They have a different maturation sequence than neutrophils do. They don't go through as many stages as neutrophils. So that's always the challenge when you're dealing with those lymphocytes, is that they tend to, there's a lot of overlapping characteristics. It's about pointing out those different, and I would just go right out and just describe them, something that a lot of our residents really appreciate when you go in and describe what chromatin pattern you're seeing. And I don't know how they're done at your institutions, but for us, we would probably put an abnormal lymph flag and then describe what they look like. And that way, and then obviously if it's a first timer, put it into a pathology review and they could go in and describe it and look in the history and kind of look at that way when they're first identified.
Yeah, we got constrained a lot when it came to doing descriptions.
Yeah.
But I did take the freedom that I did have in the conversations, right? So
Yeah.
I do believe also that we had a pro-lymph. So I've been out of the clinical realm for a little while now, but I believe we had a pro-lymph category. So we could at least like categorize them, and I would probably also insert a comment in the pro-lymph to see pathology report, because almost certainly this needs to be looked at by a pathologist, or there would be a historical record, right? If the patient's already kind of a known. But yeah, I mean, yeah, it's good to give more information, right? But the procedure constrains you sometimes.
Oh no, I agree with you. And the only reason, like when I initially started this past term, before I started teaching at UC, I was working right at the heart of the pandemic. I was working back in the lab, and one thing we noticed was that this came out of the clinical team. Like they would, as soon as we would put the AB limb flag, they'd be like, "What do they look like?" I'm like, "Well, come down and I'd be happy to sit with you and talk to you about that." I said, and they would, and I said, "This is what I see. I see nucleoli. I see this. I see that." And they're like, this is really helpful information. They're the ones that brought it to the pathology team to say, we like it when you guys put descriptions in there. So I think that was a change in the practice right there, because that AB limb flag kind of focused them, because we didn't have a pro-lymph category. So a lot of the times if we saw pro-lymphs, we would just put them in that AB limb and add it to the lymphocyte percentage. But they wanted more information. Like they wanted to know after they were treated, like what percentage of them are still pro-lymphs, because they would almost use it as an indirect monitoring tool to see if the medications that they were giving them was effective.
Sure.
So I found that super interesting.
It is interesting. And it's good that there's these lines of dialogue and communication between
absolutely
the clinical staff and the laboratory staff. Yeah.
And that's something that you won't see with everybody in the lab. Like that's something I keep pushing to people, is that not everybody has that opportunity to be able to talk to them or really wants to talk to them. That's our biggest challenge is are you comfortable talking to a clinician and telling them all this stuff? And I have no problem with it, but not everybody in the lab feels that way.
It's a fair point.
So very interesting. I love this. This is, yeah. So the cleavage, I joke around that some of the cleavage is just, again, a sign of that active, relatable transcription, translation that's happening. And those cleavings of the nuclei, they're actually 3-dimensionals. They're sort of sitting on top of each other and then twisting actively throughout all of these different things. And especially with the nucleoli, I don't see a lot of peripheral chromatin around it. That's another thing I look for. Seeing that scattered chromatin that clumps around the periphery, almost like raccoon eyes around it. I don't see a terrible amount here, which makes me think it's, again, more of a younger PLL maybe, or it's a transformed PLL possibly. So very interesting.
Platelet count looks low. Another thing to kind of
Yeah.
note as we go. I'm going to pay attention to platelets,
Yeah,
quality and quantity.
agreed.
So let's see.
More cleavage. Look at that.
Yep.
Yeah.
Yeah, so we see lots of, these kind of less mature.
Yeah.
Yeah, these would be our classic prolymphocytes. Prolymphocytes.
But then you're getting some granulate. I can't tell that well. Is this granulation happening on the side there, like these guys, or is that just remnants of the stain?
It's
looks
just
like darker areas. Yeah.
Yeah,
yeah, it's just a stain.
got it.
Yeah, and
Are
so
you guys noting some burring happening too in the red cells?
yes. Yep.
Yeah.
Absolutely. Yeah, and some of it a little bit more than others. You can kind of see like these I want to say like, yeah, nicer burr cell, up in the corner here, but then we start to see these longer projections, right? Starting to get a little on the long side. But yeah, they're there. I'm paying attention.
Yeah. And I'm definitely seeing them, I think, in almost every field I'm looking at. So
Yeah.
I probably end up calling, I mean, I wouldn't call more than 1+, but
Yep.
but I'll keep looking and see. You notice the differences in the cytoplasm too. Some of them have the nice little rims around the edge, like here. But then some have just that overall haziness with the blue, like here. That's what always fascinates me about the PLLs. There's just so much heterogeneity with everything. And I always try to tie it back into what's happening physiologically with the patient, but sometimes you can't really do that in these kind of circumstances because it can be difficult to figure out. It's not your typical clonal where literally it's an exact copy every single time. There's definitely some heterogeneity happening here. Very interesting.
One thing I think we should mention is what is the difference between PLL and CLL? Because we looked at a CLL, Dave and I did, with Prolymph. So what's the difference?
Clinically or morphologically?
Well, how do you diagnose a PLL? When does this, or I guess not, it's not always when does a CLL become a PLL, but like what is the diagnostic difference?
Yeah, so I feel like there's a flow cytometry difference. So there are different markers. I imagine there's different cytogenetic profiles too, although I'm kind of like fuzzy with those.
So
Studied them once upon a time, but
CLLs don't typically have a cytogenetic anomaly. What their unique features are your CD5, CD19 markers, which kind of overlay T cell and B cells. So that's another thing. Like you typically see CD5s in more T cells. They're part of the T cell profile, whereas CD19 is a typical B cell marker. So you can't classify a CLL with just as a B cell or a T cell because they overlap each other. Whereas I thought PLLs were strictly almost like a younger form of a B cell marker traditionally, possibly. But I could be wrong on that.
I believe you can
I
have
have
T and B cell, CLL or PLL. And I believe both instances, the T cell is not good.
No.
Yeah, it's like really, really bad clinically.
And and there's nothing cytogenetic tied to it. So from what I understood, there wasn't, there might be some epigenetic changes, but not like a chromosomal translocation, or there might be some methylation of the promoter region or some histone deacetylation happening, like those types of changes in each of them that are unique. But the way the World Health Organization classifies them is they almost go back to the idea of morphology and what they're describing and what we're seeing as a predominant morphology, because there really isn't a lot in the other realms that will help you identify those a little bit.
That's all I was going for. You two went with like, you like dove head first into like the complex. I just wanted the number of prolymphs in the peripheral blood.
Oh. Yeah, I just think from a clinical perspective, the prolymphocytic leukemia is very aggressive, very dangerous.
Yeah, and that's the other part. That's the other part that's also very interesting, is that when you look at a CLL, they actually wait to treat the patient until it becomes more aggressive. So it's again that turning of the tide. There was I just went to the clinical lab educators conference, and there was a colleague there. Her sister, she's 85 years old, got diagnosed with a CLL, but it took a year for them to actually diagnose it. And she was having changes in her white count and the lymphocytosis from a year before, but nobody was doing anything about it. And I said, well, actually, that I've heard that happen, where the CLL is a more slow, indolent, and they actually don't give you treatment until it becomes more aggressive, because then you get more bang for your buck. I've heard that among hematologists, with that they say we just watch it, and we keep watching the white count climb and climb and climb, and then they blast them with treatment to try to eradicate it. And they see much more effectiveness, less toxicity, less side effects for the patient when they do that time to treat analysis. But you're right, for a PLL, it's literally, you gotta identify it quickly and soon, because it does get aggressive and moves fast. So it's almost like waiting and watching and waiting and watching versus I gotta act now and get it going.
Yeah.
So that's what I think. That's why a lot of the, at least at my institution, why they really pay attention when you put an AB limb flag down, and they say, are these prolymphs? We're really concerned about prolymphs, because they know they got to act fast with that. So I think that's a valid point. And it's good that you're able to calculate that out, because that way they know exactly how much percentage, and they're watching that percentage. And if they see it past a certain point, then they can make a quick decision to start them on therapy. So, yeah, very interesting.
You want me to move to another field?
Sure. Yeah. Yeah, you can just start actively scanning if you like, and maybe we stop you. But I see like a mixed bag, right? So there's some of our lymphs are a little bit more mature, and then there's some of these like huge nucleoli, right? Like, you know, I don't know how you feel about these cells right here, right? But like the one on the right here looks like I would probably just hit lymph, right? And then I think this one's a little more troubling, right? With the and then this guy. What's this guy doing?
Yeah. What do we even call it? I would probably smudge that one a little bit, because it kind of looks a little bit smudgy.
Yeah, you know, it could be absolutely. Yeah, good point. It could be smudging. But yeah, so I think there's a little bit of a spectrum on our lymphs here. So
well, I think the other interesting thing about this slide is I would expect way more smudge cells than there are.
I know. Yeah. It's not a typical PLL in that regard. Yeah.
Yeah.
So. Yep. Yep.
Pretty consistent. I mean, there seems to be almost like two populations.
Mhm.
You've got these young heterogeneous, more younger chromatin, more open nucleoli, and then you've got these darker, see, almost this looks almost plasma cell-ish with
Yeah.
the
I was
soccer ball
there.
chromatin.
The one in the
Yeah.
top right, Toula? Yeah.
Yeah,
Yep.
yeah,
I thought that too immediately.
yeah, this guy. Yep. Yeah.
So yeah, definitely prolymphs. Ooh. Binucleate, anybody?
Fine. Yes.
2 is better than 1, Toula.
Two heads are better than one. Absolutely. Oh, very cool.
Yeah.
Not good for the patient, but definitely
No.
very cool spectrum. And even, yeah, see, there's so many changes in the cytoplasm also.
Yeah, I think that's the other thing to point out is that the staining characteristics of these cytoplasm are very irregular. Yeah.
Yeah. Those are always fun.
But I think
All
that's
right.
something, Dave, you point out pretty consistently, that irregular staining is something that's common to malignancy.
Yeah.
Yeah.
I
Yeah.
think most people miss the dysplastic features and they kind of get trapped in the story, a narrative about the slide being the problem or the stainer is the problem. And I think it's fine for people to make a new slide, stain it again, maybe use a different stain technique, right? Try to isolate the variable. But I think what you'll find 9 times out of 10 is that that's just what's going on in the cell, right?
Agreed.
So, that could be a marker for some kind of a dysplasia or something. So yeah.
And that's something to note with the World Health Organization, is that they're making note of a lot of the dysplastic changes that are commonly seen with a lot of the different leukemias. Is that and I agree with you, before sitting and staining, I tell my students all the time, I said, QC your stain with your red cells. Your red cells, since there isn't much happening with the red cells, you're going to get an idea of the quality of the stain with the most abundant cell you're going to see, which is typically your red cells. There's 5 or 6 million red cells. There may not be 5 or 6 million on the smear, but QC your stain with your red cells, and that'll give you a good idea if what you're dealing with is something unique to the slide, because it's going to affect all of the blood cells, versus something that's just unique to your white cells. Before taking an extra hour, making a new slide, drying it, staining it,
Yeah.
and then relooking at it, hoping to see something different, when in fact that's just the nature of the beast.
Yep.
You can't, yeah. So I always tell them, QC your slide with your red cells, and that'll give you a good idea. And that's why I spend a day or two literally pulling out a slide that's super acidic and is favoring the eosin. I said, tell me, do you think you're looking at all eosinophils, or do you think these are neutrophils? And then one that's more on the basophilia, I said, are all these neutrophils toxic, or are they actually there? I spend a day or two like sitting down and having them look at, and they're all normal slides. They're not just, there's nothing happening with them. It's just how the stain affects your interpretation of that. And that's super important. So I agree with you, Dave. That's a very good and valid point, is like, you've got all of these red cells all the way through, and it's like, yes, there's not much happening with them, but that they still have validity there to kind of help you gauge, all right, is this a poor staining quality, or is there's something more happening here?
What do you think, Melissa?
Very
Is there anything else we can kind of get off of the slide, or?
I think that's about it. I can scan a couple more fields if you want.
Yeah, just I guess a couple to close here, and we'll see. I think I do agree. We'd probably call some kind of a kinocyte burr cell.
Yeah.
Ooh. So very reactive looking lymph there, right?
Yeah.
And so we had like a plasmacytoid looking.
Yeah.
So yeah. Interesting.
There's a couple of those.
Yep.
Platelet count definitely looks low.
Low.
Probably below 50,000 at least. If I had to speculate.
Get my Yeah, and some mature lymphs, you know, and then our pro-lymph population. Very well could have been like a CLL that's starting to transform or something like that.
Agreed. That's always so interesting to me. Yeah,
Cool.
very
Well,
cool.
I think that's all we have for this slide. So Toula, thank you for joining us.
Thank you for having me. This was great. I had a blast with you guys all again, no pun intended. But thank you all for having me on the show. This was really, really great. And I had a lot of fun with the slides and with both of you. You guys are
pleasure's all ours.
thank you again.
Yeah. And everybody else, thanks for watching.
Thanks for your time.